Hello, welcome back to this second session. My name is Sabina Brennan. I'm from Trinity College Dublin. Just before we start the second section, I want to give you permission to turn your phones on and put them on silent, and to tweet using the hashtag DemPal. It's on the back of your brochure. So tweets very welcome, and other sharing on social media. So just before I introduce the speakers, I just really want to set the scene and really just explain what the purpose of this session is. We have a room full of experts, and the goal for today is to use that expert knowledge to inform research questions for our next funding applications. So really what I want you to do is, when the speakers are up giving their talks, to be taking in the knowledge that they're sharing with you and using it to think of research questions. Then we will have 25 minutes after each speaker to go to the floor. And what we would like the people who want to speak in the floor, what we would like them to do is make suggestions of potential research questions that we can discuss, bounce around the floor, and use our expertise to really come out with something quite concrete at the end of the session. If you do have other comments relative to what the speakers talk about, please use the comment form for those, put those in the box, and we can come to those at the end of the day. So think research question focus. Now I'd like to introduce you to Joe Eustace, who's going to speak about research methodologies.
Thank you very much. It's a pleasure to be here and speaking on behalf of the Trials Methodology Research Network. I'm going to issue, first of all, a disclaimer. First of all, is that I am a nephrologist, therefore I am the person who knows least about this content area of anybody in this room. The second one is that, given the fact we've got 15 minutes to talk about methodological issues, 90% of what I'm going to say, 90% of you already know. So this is going to be a pretty quick tour through some of these issues in an attempt to provoke some thoughts for the subsequent discussion. I'm going to talk a little bit about the recent supports the HOB has funded to facilitate patient-focused research, talk a little bit about generic network development and some methodological limitations and opportunities that may be relevant, and all that we can pick up hopefully in the discussion. This jigsaw is the framework that the HOB puts around to explain their recent support of patient-focused research. On the right-hand side here, we have the support of clinical research facilities and centres, which the centre that I work with, the clinical research facility in Cork, is pretty typical. So that has a wide range of goals, as you see there. They're all pretty standard. There's a strong focus on quality. It's pretty agnostic as to what the area of research is, so we'll research any research area or specialty. It has a strong focus on clinical trials and a strong focus on training, and particularly of training of methodologically appropriate ways of going around doing things. Of the 6 clinical research facilities that are around the country, they have a total of about 50 years of experience in performing particularly clinical trials. The data here is the current figure compared to a year ago. They've conducted 174 trials, employ 134 people. They work with 14 hospitals, and they work with 250 odd investigators. So that's a pretty substantive support network. If anybody is trying to roll out a comprehensive program of research around the country, there at least is now, compared to 5 or 6 years ago, a framework of clinical research facilities that is dedicated towards doing it. Let me re-emphasize the fact that they are available, but unfortunately they are not completely funded for exogenous research. They can only work on research projects in general that come in with a funding element attached to them. What the HOB funded next was a coordination entity to help coordinate the work of those 6 clinical research facilities. That has a somewhat clumsy title of the Clinical Research Coordination Ireland. It's based on the Canadian equivalent. And its role, again, is to help provide an overview, a support structure, and a coordinating structure, particularly for the setup and conduct not only of clinical trials, so it has a strong focus on trials, but also of large-scale observational research projects. So that is much less involved at the design stage and at submitting a grant as when there is approval and you're trying to establish a network and set up the different elements of those networks to conduct the project. Obviously, you also have to think about engaging with that a priori when developing the grant if you're going to make sure you have the necessary resources and wherewithal to conduct that. And again, it's the usual suspects. It's the 5 university hospitals with schools of medicine, undergraduate programs, but this also facilitates with other centres. It's not purely limited to those universities, so it also interacts with Limerick, with Belfast City Hospital. Actually, that's largely aspirational. We haven't really done much work in Belfast yet, but also on the paediatric side of things of less relevance here. The next support element that's been recently funded has been the TMRN, which is probably particularly of interest to this audience. So the Trials Methodology Research Network is there really to provide methodological support in the design, particularly, and in the reporting of clinical trials. That is more or less exclusively focused on clinical trials. It does this in 3 ways. One, by increasing training and education through a series of webinars, 1 or 2 day courses. We had a 1-day course here about a week or 2 back on regulatory issues in clinical trials. We have a summer school coming up in September, the Irish summer presumably. It also supports scholarships both at undergraduate and postgraduate levels. It supports research and innovation, as has a very limited budget for methodological research. The main workhorse for this are these SWOTs, so studies within a trial. And so this is the concept that you're doing a trial, you're doing a large project, and you embed within that a separately funded project that addresses a methodological issue. That could relate to recruitment, it could relate to ascertainment, any elements of issues. Now, obviously, there's a challenge here. It's important that that research in itself shouldn't introduce any kind of information bias into the primary study, but that's one of the tricks, one of the challenges, one of the expertise of designing these and embedding it within a study. So that SWOT is not really going to inform the study in which it's being conducted usually. What that does do is inform your next study that you go on from there. I should think more than anything else, this is really a quality marker of a research group that's know what they're doing and is serious about developing the research in that area, because it means they're not only focused on what's happening today in the current grant, but also long-term methodological issues to address relevant questions. Another area of key concern to the TMRN is core outcome sets, which we'll talk about in a moment, perhaps in regard to the topic at hand, as well as evaluating methods for dissemination. It's particularly around systematic reviews and meta-analysis. From the point of view of support, there's a trial methodology and reporting advisory service. So that's really the group of people in Ireland who are interested in methodological issues and who are happy to support in the design. What's particularly useful for this, that also integrates with the UK equivalent, where there's a far greater breadth and depth of expertise and it's available within Ireland. And so certainly for more complicated or complex issues, it can be facilitated in engagement with the appropriate resources in the UK via the TMRN that can be very useful, again, certainly in a grant application. TMRN is also in the process of developing a database of expertise within the country, which is still under development. So obviously, why is this relevant to you as investigators? Obviously, many of those reasons are self-evident, hopefully. The bottom line, however, is that throughout much of Europe, the quality, the standards of methodological issues in patient-focused research are suboptimal, probably compared to the States, certainly compared to what is possible. In Ireland, the general level of awareness and standards of that falls, in my opinion, well below the European average. So these are things where there are major deficits in our training and our work practice, how we go around designing many of these issues, how we avoid problems. We don't initially have much of the expertise that we need for dealing with these, so it's critical that we engage both with local people, such as they are present, and internationally with experts that can help address these issues if you're going to be competitive. And much more importantly, if you're going to have research that's going to address the clinical question that you want to answer. If all you want to do is a medical journalist and produce papers, maybe it makes very little difference. If what you want is papers that will really implement change and improve the quality of care for patients, then it's critical that those inferences are valid and that they're implementable. And that's why it's so important to have those design issues appropriate at that stage. The final piece of this jigsaw is the clinical trial networks, which are disease-specific. Obviously not shown here, but also there is the palliative care network, which the HRB also co-funds. So there should hopefully be another call for this in about 18 months' time. This was a fee of about support of about 5 million euros for those networks that vary among issues like stroke and perinatal care. And one of the critical determinants of the developing of that network was that the group or the consortium had some track record of working together. Now, this was not for any of these networks the conduct of prior to that grant of a clinical trial. In many cases, some people got away just having done some extensive surveys among the potentially interested parties or some very basic level observational research. But even that element was critical towards achieving a demonstration that people could work together and collaborate sufficiently as was required for success under that grant process. And again, the expectation is that there should be another call under that program, probably somewhere in the next 18 to 24 months, so the formal date for that hasn't been announced. If we're looking at funding opportunities, because funding will determine everything, there's absolutely no doubt about that. Best wishes in the world will achieve very little in the absence of dollars to actually support it. Obviously, you have the Health Research Awards. The basic work org of the HRB awards is $330,000 for about 3 years, mainly focused on observational research. And there should be a call for that later on in this year, and that it's open to help for patient-focused research or for health services research. The HRB Definitive Intervention and Feasibility Award is currently open with a closing date in July. Now, to do a definitive intervention, you really need a successful grant application there. You really need extensive pilot data. So if you don't have that, you're certainly not applying for up to €1 million from the HRB for 5 years for a definitive intervention. But this award also allows you to do feasibility awards. That, again, is probably going to be of the order usually of 200,000 to 400,000. It can be for up to 5 years, so that would be unusual. You're probably thinking about 2 to 3 years. And the beauty of this is that feasibility, as it suggests, doesn't require any prior studies. The success of this really will be determined by what is the impact of the subsequent trial that you're planning on doing, the coherence of the network. And this is specifically designed for addressing methodological or pragmatic issues for down the road. It can either be in the form of a pilot study, or it can be in the form of feasibility addressing issues like outcome ascertainments and ways of doing this and the validity of those. So this is a vehicle which, if you're serious really about getting into coordinated research, you've got a deadline of about 6 weeks, but if you're serious, you really have to get something into that award because it's only going to come up, well, the next one maybe 2 years' time. The network call we talked about briefly on a European front, the only one that I'm aware of that would be immediately relevant is comparing the effectiveness of existing healthcare interventions for adult populations with the reference there. So that's a €6 million for international funding. Ireland's had tremendous success. UCC is involved in 6 Horizon 2020 FP7 projects at the time in the healthcare area. We coordinate 2 in the clinical research facility. So these are big grants, but still achievable with the right consortium. The fact that it's a 2017, it's a 2-stage grant. So the first stage, which is a much smaller endeavor, is in, best of my knowledge, October of this year. So actually the first stage application is later on this year with the full application going in early next year. And obviously there's a variety of other funding opportunities that you'll all be aware of. Again, it's very hard for me because I don't know exactly what stage you are as a research grouping, but I thought I'd throw in some generic comments about developing a network that seems relevant for a variety of the people that we work with. The first element you obviously becomes critical is what is the focus? Obviously, the general domain of palliative care in cognitively impaired patients is established, but within that domain, what is the hypotheses, the research questions that are relevant? And obviously informing this, the critical thing, both for developing this yourselves as well as for grants, is reviewing what is out there for meta-analysis or systematic reviews. Now, the interesting thing, of course, in the area specifically that you're looking at, which is such a difference, I would suspect, for palliative care in somebody who's not able to verbalize, for someone who is substantively cognitively impaired, is possibly dramatically different to that area in a general palliative care setting. And so one of the elements about all this that what might be applicable as some of the systematic reviews and meta-analysis in the general area of palliative care may not be as relevant, but that again is an early step that should be teased out. How much relevant information is out there, or of the key questions are addressed in the general palliative care literature, are they applicable to the patient population that you're looking at here with dementia? And if not, that gives rise to a whole set of reasonable research questions, and the fact that there is no valid research is an equally important thing to observe. You want to develop, again, some understanding of the available local population, practice patterns and circumstances. That can be done quite simply by cross-sectional surveys or by a more substantive, possibly registry data with follow-up, or obviously more formal cohort studies, though obviously a cohort study itself is going to take longer and require a greater degree of resources. You've got to come with a development plan. That really means developing a core group that puts together a business plan. It's amazing how many people want to do a lifetime of research but never develop a business plan as to where the potential research opportunities, who's interested in this, and at the very least you have a superb start here by having all the relative stakeholders gathered in one room, but that has to equate into a development plan for the long-term evolution of this research. From a methodological viewpoint, if you end up doing trials, as you know, there's a dichotomy here between pragmatic trials, which are often comparative effectiveness, many oftentimes involving care pathways, versus a more pharma, explanatory, efficacy type study that's looked at the implications of a single medication or something along those lines. So it's much more likely that you're going to fall towards the pragmatic spectrum. So that literature that relates to conducting pragmatic trials, that's probably going to be the seed bed that's going to be particularly of interesting for some of the work that you're doing, I imagine. From a design issue, because you cannot apply very often care pathways or educational pathways at an individual patient level, you've got to do it in a clustered fashion, and that's going to bring you down to cluster randomization, where the critical thing to establish, often impossible unless you've got time for several months beforehand, is the interclass correlation. How much different hospitals agree in their practices and their outcomes, how much are different units. So you go to a statistician and you want to do a clustered randomized study, what they need to know is that interclass correlation. And again, you're not going to be able to find that from the published literature, you're going to have to go out and find that yourself. Agreeing a core outcome sets for the disease area that you want. If you don't have one, and I didn't see any evidence in the literature there's one out there, that's going to become an equally important framework. It's something we should presumably talk about. And again, for these complex interventions, there's a well-developed pathway along the lines of the MRC framework for complex interventions, now adopted internationally, used in the States, used around Europe, and that again is the framework that you should very much adopt. Of the neurological challenges, again, I'm not going to go through these because you're much more familiar with them than I am, but it's one element that you have multiple relevant perspectives in this. It's not just the patient, it's the patient's family. The family is not an individual entity, it's composed of individuals. It's all of those elements that you need to take cognizance of. There's a range of ethical issues, none of which are insurmountable by any shape or form. There's one interesting element as a subject of research in this, partially the the physician as well as the patient, because in care pathway research is an evolving thought that what you're really doing is experimenting on the physicians as much as on the patients. One critical thing that we should probably end up talking about is the validation of outcome scales. Obviously, the main workhorse for this in most areas is patient-reported outcomes. That's impossible in a patient that cannot verbalize. And so that gives rise to the whole challenge of validating outcomes, qualitative outcomes in the setting of palliative care. There's a nice example here, which you may all be very familiar with, the end-of-life care and dementia scales. I'm not going to go through this. We can always come back to it. But again, there's some limitations with the validation of this that are worth thinking about. And just to point out that validity, the reproducibility of that test has a huge impact on your power. If you have a reproducibility coefficient going from 0.7 to 0.9, that allows you to reduce your sample size in a trial by almost 20%. That's a huge impact. The final thing I'm going to say is that a huge opportunity, I got to believe, in this area for the interaction of information technology, either for things like symptom diaries, for things like dealing in the bereavement experience of patients, of patients' families, where you're not going to bother them in the day of a death or in the subsequent days thereafter, to be able to do that informally through some application on a smartphone, something along those lines. There has to be multiple issues there, and that's going to very strongly feed in, I think, to a lot of the desires for innovation that you'll see coming out of European funding agencies as well as Irish agencies. And with that, I stop, and we have a discussion. Thank you.
Thank you very much, Joe. It jumped out to me very specifically. Do we want to be medical journalists, or do we want to ask research questions to address clinical issues? Open to the floor now for anybody who wants to start the conversation around research questions.
Thanks very much, Joe. Very interesting whistle-stop tour there. My name's Emer Begley. I'm from the Alzheimer's Society of Ireland. And I was wondering if you could talk to the whole issue of public-patient involvement in research. And I know the HRB have really been promoting this, but from, I suppose, we don't like to use the term patient when we talk about people with dementia because we see them as a whole person. But for ourselves, there is... we see the benefits, but there's also challenges because we're often seen as gatekeepers for researchers to access people with dementia in that way. There's capacity issues, but I also think there's capacity issues within the research community as well about how to meaningfully engage with people with dementia and avoid tokenism.
Totally. As you want us to be interactive, let me first of all ask, how many people here are actively engaged in a PPI program in their research? And so why don't we get some feedback as to what the impressions have been of that? Because you have experience in it. If you want to, if we get a microphone.
Emer and I were talking over breakfast about just this, but I was saying it's really, really difficult, and that's my honest. I wish I could stand here and say with some huge authority that I've got this down. I know how you do this. I know how you use you engage people with dementia in thinking about complex evaluative issues. And I don't, I think there are some guidelines that exist that are helpful, but you have those, and they're kind of. Then you're sitting there with people with dementia or a person with dementia, and you have really complex issues you want them to comment on, but you cannot outpace them, and you can't do any of the treachery of the things that we can easily do to people with dementia, and it's very, very complicated. And I think there's a research study in just really understanding.
I think that's exactly it. So the bottom line for all of this is you have to have a work package for patient-public engagement now if you're submitting any kind of research, HOB or otherwise. So you have a standard platform that no one understands how it's going to be evolved. AIIHPC is developing a working group. You should certainly have representatives on that, looking at those issues. What you do is you put in a standard PPI work package, which often amounts to very little meaningful, and it's a perfect opportunity for developing a SWOT, examining those issues in whatever research project or trial that you are working within. The simple answer to your question from a viewpoint is that other than saying it's critical and important, I don't think we have any better idea as to how we'll go about doing it appropriately for many of the projects that we're working with at the moment than anybody else out there. A lot of people are looking to the UK, but from my read of the UK, the experiences there are very mixed as to how much of that is lip service and how much of that is substantive. Okay, other issues regarding, I'm told I have to, in the next 15 minutes, come up with 3 study designs. 12 minutes left.
Adrian Trelaw from Oxley's in southeast London. Just to add, actually, that PPI is actually marvellous, really. It can be incredibly helpful. It can hone down the discussions that you have, focus your arguments, and make you think in different ways. So it can be an extremely helpful process.
That is fabulous, because you just became the work package lead for the work package in PPI for the whatever the group.
Hence the second half of my comment, which is that Demetrios Adamis, who works in Cork here rather marvellously now, actually did some research with me in London and tried to get really good consent to people with dementia for entry into a delirium study. And what we demonstrated, and we published it as well, is that by trying to get consent and trying to involve people with dementia, you actually then excluded them from the study, thus rendering the study invalid. And I think the real difficulty with PPI in dementia studies is an ethical one of worrying that you skew the involvement and the research away from the places where you need to do the research towards settings with milder dementia. Now, clearly, if you're researching into mild dementia, it's fine. But if you're actually going to start doing research into advanced dementia, deliriums, times when people are at a crisis of capacity, then actually there are some real ethical issues to think through in terms of how you make sure that the study remains ethical by being representative.
So clearly important, highly relevant from a funding viewpoint. Clearly we have no idea how to go about doing it. So put in, although it can be done very well and it's clearly rewarding, put in a 1-year feasibility award to the HOB in 6 weeks' time for 100,000 to figure out how you get PPI involvement in a population of cognitively impaired people. Okay, next. Two more designs required.
Just a comment. Is any thought about advanced directives for people to participate in research down the line? What about that?
Yeah,
Joe.
There is not a well-defined legal framework for that now. And again, I'm no expert in any of this area. You would imagine that there would be enormous appeal if you were looking at a group of patients who are cognitively impaired in getting their impressions at a stage where they are able to express what their wishes would be in the event that they get to the point where they're not able to express that. And that certainly that type of research based around people's future expectations and desires, and then the ability to equate that into an advanced directive, the legalities of which are a little bit more complicated now, and certainly you know much more about them than I do. I am not aware of any project doing that. Let's put it that way. It certainly is a target that's well worth addressing.
So perhaps a national directory of research volunteers. You sign up for a directory and you say, whatever happens to me in 20 years' time, I'm willing to be involved in XYZ types of research, and it could be a resource.
Okay, next issue.
I've been told to stand up for the camera.
Outstanding.
In the UK, we do have an initiative called Joint Dementia Research, where people with dementia, family carers, and indeed any of the general population can join it. And there is quite a literature about consenting to be involved in research for people with dementia, and the argument that becoming part of an advanced care plan as well. So it's already sort of being considered.
So there was a very good framework there to base it on. It strikes me that many of these elements are going to be culturally related. And so you can always make a strong argument to just pilfer the research that's been done over in the UK or anywhere else and say it's critical that you validate that in an Irish population context, which is reasonably different, and you take all of that work, and then it's pretty easy just to put a validation experiment showing it's as relevant in Ireland as it is in the UK. And I think that is a good idea as distinct from just a useful way of getting things done, because they may not, there is huge cultural difference, and this is a strongly culturally mediated issue. Okay, what about core outcome sets? Do we have a set of core outcome sets for palliative care of a dementia, of a patient with dementia? I take that as a no. Maybe?
No.
Excellent. That's a, what about the presumably? Sorry, please.
One of the outcomes which comes strongly from palliative care is distress, because palliative care is about managing distress, and I'll say a bit more about that this afternoon. But actually, alongside distress, there is comfort, and they're probably separate variables. One is distress, one is comfort. But in fact, to date, there are no scales that measure distress or comfort in advanced dementia. So actually, that might well be a priority, because we really, at the moment, we measure things like challenging behaviour and so on and so forth, which are not the same as the patient's experience of distress.
So, I mean, I think that is an absolutely critical starting point. It's also a starting point which many of the funding agencies now are increasingly interested in. If something doesn't exist, you set up a consensus conference where you invite everybody that had something to do with this in the palliative care or elsewhere. You find someone to fund that, and you decide what are the potential core outcomes. How do you define distress or comfort in a patient who can't verbalize them? And to some extent, I'm thinking about this, one of the things that really strikes me is that from an IT viewpoint, is, you cannot verbalize, but the presence of distress must manifest itself in some way. Is there an IT solution? Obviously, you could look at general physiological parameters, but that may be arranged for so many reasons. If you're dying in the context of sepsis, you're going to be febrile, you could still be perfectly comfortable, you may not be causing. But is there any method of IT-based improvement that moves us beyond, that we get some signal from a patient that allows us to determine comfort or distress? And even if you don't, it's a very tenable hypothesis, which with the integration of IT and pushing patient comfort and pushing that agenda is something which a lot of people are very interested in potentially fund. So again, the limitation of this population that they cannot verbalize in an area where the outcome is classically always a completed qualitative questionnaire. How do we get around that is the central issue. And obviously you can take proxy opinions, but even there from a methodological viewpoint of what I've seen very briefly in the data of some of the trials where they ask one family member or the nurse. I mean, I did not come across any good study that asked all the family members and asked what was the concordance across that, or how does that compare with the nursing. I know that's been done in palliative care studies, but in the area of dementia, I didn't immediately see any elements along those lines. So certainly developing a conference, identifying two core areas like that, and then getting some people from outside the box to come and give some pretty out of left field ideas as to how you might do that and see what you generate, while at the same time establishing what is the most agreed set of core outcomes. What's the best set of that? That's EOLD scale that's there in the literature from one or two of the trials that have been conducted to date. If that's the state of the art at the moment, you adopt that and you do another work package that looks at interesting exploratory ways of doing it better, and that makes sense. That's the second study.
Just, I think you're, bringing up great ideas in terms of particularly, say, IT, and then going back to your talk in terms of what you said about a family is not a single unit. It's made up of multiple people. But frequently in palliative care situations, there's meant to be one representative of the family, and they're the person who gets all the communication, or in fact gets asked about what do you think your mum would like. So whether there's some piece of research around an IT solution that gathers the info, because usually it's resource issue that you can't ask or have a conversation. So an IT solution around gathering everybody's viewpoint, including, as someone mentioned earlier, the care assistants, feelings, the individuals, if they express something during the course of their care, a way to gather information that may build a bigger picture of what a person wants, rather than a single question. We can't ask the person today what their opinion is. So maybe there's a piece about intervention development.
Somebody know of a smartphone app, or is there any research that's actually done that in a palliative care setting? I think that's a superb. The whole idea of exploring the grieving process of the family, where of the studies, I forgot the name of it now, one study had asked the research nurse and the other study had asked the family 6 weeks later, where you've gone into multiple dynamics that may have influenced you, and maybe with someone who's had a very slow decline, maybe your opinion 6 weeks later bears very little relation to what it was in the first week. So there's loads of methodological work that can be done there, I think, using appropriately apps, especially with a population that's increasingly comfortable at using apps for virtually everything else in life. Please, there's a microphone somewhere.
Sorry, stand on. My name's Carmel Gagan, and I was a carer for my mom who had dementia. So I'm here from the family carer perspective. My dad also had cancer, and he had a very brief illness and hospital. So I wanted to speak just earlier when we were talking about the nurses were the most important people that we came across. The medical people didn't, like i.e. consultants and GPs, really didn't want to know what the patient had to say or the family members. And I'd say there's a major issue with GPs in this country. From giving early diagnosis, and that went for my dad with cancer as well. But anyway, my mom got a very late diagnosis, and once she got the diagnosis, and probably prior to that, her voice just didn't come into it at all. And she was pushed aside completely, as was I, because I was the primary carer, and I think they think we're a little bit nutty or something, which we probably are when you're going through that, because you're totally frustrated and you can't get answers. But just there's something, and research, I've only discovered about research as well, and I've been involved in a few pieces. Now I understand how important research is. We don't, out in the public domain, understand about research. I found it frustrating that it takes so long, and it's shelved, a lot of pieces when they're done, important things, especially to do with dementia. I'd love to get involved and put myself forward and I would be happy to sign up, further down the line if I develop dementia, because nobody knows. But I think you need to come out into the public as well and explain to us about research, the wonderful work you're all doing. And then we probably would get involved.
Yeah, it's a critical element. One of the goals of the TMRN is to try to disseminate results, raise the profile of research. You may have seen some of the work it was doing, like having clinical trials run out of schools recently for World Trials Day last week. There's a huge ground, and this whole area you're looking at, because it's so emotive, is a very good way of illustrating that in a public context. And so certainly I think that is a very, very appropriate and very important element of any research component that has been driven along those lines. If we get back to the research, the core research elements, is there a registry And if there's not, who's going to develop a registry or who's going to drive cross-sectional? You cannot do a trial unless you understand your population and unless you understand, the pragmatic realities of where you're dealing with. And so that requires, at the very least, a registry or cross-sectional studies. Obviously, if you can do full cohorts, that's wonderful, but it takes time to take money. So is there anything like a registry or a series of cross-sectional surveys that's done particularly in this area? And if not, how do we develop one? Please.
Sorry, Emer Begley again from the Alzheimer's Society. Just to say, for a point of information about dementia registries, that the ASI have commissioned Kate Irving and her team in DCU to look at a feasibility of the development of a dementia registry, and they're at the data collection phase of that. If people are interested in hearing more about it, please talk to me, or I'm sure Kate as well. Sorry for nominating you there, might be interested in talking to people afterwards. But it's really about looking at what data is currently being collected on people with dementia and how is it being used, and to start a national discussion around that.
And the only other comment I'll make about that is that it's so easy to collect data. It's critical that that information is speaking to whatever direction you think you're going to be taking your research. I mean, obviously it's useful just to know the number of patients that are out there and some of their clinical, etiologies and the rest of it. But if you're particularly trying to go in a direction looking at research for developing one area or another, whatever that is, you want to have gathered at least some information about that in the surveys, which is what that interaction is. So it's critical that the research group interacts with whatever body is planning on driving that kind of registry or survey to capture some of that information.
We have about 2 minutes left, so to talk more about researchers. Yeah.
Mervyn Taylor from Sage. I appreciate that this may not be hitting the target in terms of your research requirements, but just the experience of our service in the last 18 months that we've been established. I would say about a quarter of our work sometimes goes on what I would call the actively interfering relative, the AIR, which seems to be about relatives in splintered families actively working to actually insist that the person has dementia and that they have absolutely no capacity whatsoever. The confusion and the turmoil that this causes, and the incredible waste of health and social care resources, and the amount of time involved in this, not to mention the legal resources that are involved, and a huge number of other ancillary costs that never get thought about. I really think it would be of benefit if there was some program that could actually look at the cost-benefit analysis of actually a planning ahead program, which would measure the effectiveness of people actually planning ahead, so that we actually could have people speak for themselves. In other words, self-advocate for themselves at a later stage, for events later in life where they have not got full capacity, but which actually can push aside some of this enormous waste of time and resources, where family members who very often not been engaged suddenly become engaged, and where the issue is very often that there are resources available that they want to get their hands on. I'm sorry to talk about these very blunt and grim things, but this is very often what we are seeing in a substantial amount of our work, is people trying to insist that somebody does not have capacity and spread rumours, and there's terrific family dissension, and very often at the core of it is a form of elder abuse.
We've just run out of time, but I do think that speaks to a research question. How can we make more efficient and effective use of resources and ensure that the right people have voices? Thank you very much, Joe. We're going to...